Good morning, one and all. I, Dr. Ketki Patni, on the behalf of Department of Neurophysiotherapy, Dr. APJ Abdul Kalam, College of Physiotherapy, Praura Institute of Medical Sciences, Loni. It's my privilege to welcome all respected professionals, speaker, and all dear participants for webinar on the occasion of World Stroke Day 2020, and its theme is Join the Movement. Physiotherapy department was started in 1976, extend rehabilitation. So our institute, it started in 1997 and it is one of the reputed institution of India. Dr. Abdul Kalam College of Physiotherapy, the institution is named after visit of His Excellency, then President of India, Dr. APJ Abdul Kalam to the Praura on 15th of October 2005 on the occasion of his birthday. Praura Rural Hospital has been conferred National Award under the category of Best Institution for providing services to senior citizens and awareness generation. The award was presented by Honorable President of India, Shri Pranab Mukherjee, in National Awards Vayoshreshta Samman organized by Ministry of Social Justice and Empowerment by Government of India. It is held at Vigyan Bhavan, New Delhi on October 1st, 2015. This college has produced nation's finest physiotherapists each passing year who are working across the globe. The institution is flourishing under the leadership of Honorable President of Praura Institute of Medical Sciences, Dr. Rajendra Vikhe Patil, and Vice Chancellor Dr. Y.M. Jairaj sir. Before starting the webinar, we must pay tribute to our great visionaries, our founder father, Padma Shri Dr. Vittalrao Vikhe Patil and Padma Bhushan Dr. Balasaheb Vikhe Patil and Mother of Soil Sindhutai Vikhe Patil. So now today is World Stroke Day and it is celebrated in all over the world as 29th October 2020. 1 in 4 of us will have stroke and it is leading cause of death and disability. So don't be one and join the movement. Be a part of world's biggest chain to prevent stroke and to raise the awareness. As everyone knows, stroke is occurred due to poor blood supply of brain and which causes loss of movement of one side of body called paralysis because of its mainly risk factor, that is alcoholism, hypertension, obesity, cigarette smoking, diabetes, mellitus, tobacco chewing. So always prevention is better than cure. To acknowledge stroke, we are helped to improve the quality of life. Our department is organized various activities on World Stroke Day to increase the awareness of stroke, like tele-rehabilitation through Skype to the rural area, stroke awareness camp to improve awareness in village people, and awareness program through FM radio. These are the few glimpses of it. Now, this year we have organized webinar on emerging trend of stroke by our renowned guest speaker Dr. Prabhat Ranjan sir. I am welcome you to sir. The stroke topic is webinar topic is role of physiotherapy in achieving functional independence in stroke. Dr. Prabhat Ranjan sir is MPT in neurophysiotherapy as well as PhD scholar and certified in basic as well as in advanced level of NDT and BOBAT. He is currently working with All India Institute of Medical Sciences, AIIMS, New Delhi in the Department of Neurology from last 12 years. Sir has many accomplishments. He had been resource person for more than 80 workshops in India on the topic of NDT and BOBAT. Had been visiting faculty in several colleges around Delhi NCR since last 8 years. Organized 7 international conferences of physical therapy in AIIMS New Delhi. Organized and attended workshops on several topics in Delhi. member board in several universities, has been keynote speaker in several national and international conferences, is member of the for Physio and Occupational Therapy. He is executive member of National Indian Association of Physiotherapists, as well as he is certified in basic as well as advanced level of NDT and bowel. It's my it's my privilege to welcome you, sir. Hand over to you, sir.
Thank you very much, Dr. Ketki, for the nice introduction. One thing I will correct, you have said that I am executive member, IAP. Now I am ex-executive member. I am not there as executive member, but I am ex-executive member of IAP. So as today we are here to commemorate the World Stroke Day, and this is to commemorate it to, as Dr. Ketki said, to aware the society, aware the people about the impact of this stroke, and it is increasing day by day due to the lifestyle, and it is one of the most common non-communicable disease leading to an epidemic. So this is one of the this has been said by the WHO that it will be a pending, it is an epidemic in pending, and if it is not taken care of right now, then most of the population, as you said, that 1 out of 4, it is already a very high prevalence of this stroke in society. So this will lead to more disability, and the productivity of any nation will go down. So now I will start with my presentation, that is on the achieving the functional independency out of stroke in the stroke survivor. So my PPT is visible.
Yes, sir, it is visible.
So thank you for the confirmation. So my topic, as I said, that it is role of physiotherapy in independence in stroke. Because what happens that after stroke, the survivor is having a problem in doing any of the motor activity. So motor activity is one of the main concern, and which leads to functionally dependence, means to perform any of the ADL also, they become dependent initially, and slowly and gradually with the role of physiotherapy it improves, and when it improves, the functional independence also improves, and the subject is able to perform or do his activity of daily living, such as in walking and then performing any fine task also. So as we all know that what is stroke, it is, the other name is cerebral vascular accident. It is a sudden focal neurological deficit resulting from ischemia or hemorrhage or lesion in the brain. Out of the two hemorrhages associated with high risk of death, and it is our third leading cause of death and number one cause of disability. As I said, that it is a pending epidemic growing in elderly population, as well as it is due to the increase in lifestyle disorders. There are a lot of non-communicable disease leading to stroke. It is of two types. One is the ischemic stroke, and ischemic stroke is the most commonest stroke, and it occurs due to the obstruction in the blood vessels, and 8 out of 10, suppose 80% of the cases, you can say, falls into the ischemic stroke. and it is due to the obstruction in the blood vessel. Then is the hemorrhagic stroke. Hemorrhagic stroke is due to the rupture in the blood vessel, and most common cause of the rupture of the blood vessel is aneurysm. Aneurysm is abnormal bulging in the blood vessels, which is not, if it is not what happens that most of the time it goes unnoticed and suddenly it ruptures, and then it comes up with a symptom. But classical symptoms may be there, such as headache over the eyes or inside the eyes, momentary vision loss. These all may be the symptoms which may go unnoticed. So as per awareness part, whenever you are one is having a continuous pain over the eyes, suppose in the frontal region or behind the eyes, and sometimes momentary visionary loss is also there, then I will suggest that they should meet the physician to get it ruled out whether it is due to any other pathology, underlying pathology such as aneurysm. So aneurysm sometimes may become fatal also while it when it ruptures. So what is one of the cause of the stroke? That is hemorrhagic stroke. One form of stroke is transient ischemic attack. This is also known as TIA. TIA, it has been said because there is a recovery within the 24 hours of the episode of the stroke, and it is a version of the period, and it will 6 hours, 2 hours, 12 hours, or within 24 hours, the sensory and motor loss is recovering, and the prognosis is very good in this. But one thing has to be remembered, that TIA is an alarming sign of a bigger episode of stroke. So one should be alert as a physio, as a healthcare worker. If one comes to us with a history that, sir, in the morning I had the weakness over the face, over the arm, over the limb, but sometimes what happens that they may not have the facial weakness or the limb weakness, but there may be slurring of speech in them. So this is also one of the indication of the transient ischemic attack, or you can say the first sign and symptom of the stroke. So slurring of speech, and then he says that after 4 hours, 6 hours, or after 24 hours, I will find I was walking, my voice improved, my facial weakness improved. But as a healthcare worker, we have to suggest him to see a physician to rule out whether it was an episode of stroke. Sometimes facial deviation is due to the lower motor neuron type of palsy also, but facial palsy is there, then also it should be ruled out whether upper motor neuron is involved or not. So one of the international mnemonics which has been designed by the WHO, and it is one of the important thing nowadays. This is being spread as an awareness to identify the stroke as early as possible, because timing is one of the important factor in getting the treatment in time is very important in stroke. So it is known as FAST. This mnemonic is known as FAST, F-A-S-T, where F stands for facial drooping. There is a facial weakness. A stands for arm, or you can say limb, upper and lower limb weakness. And S stands for speech difficulty. So these three symptoms, or even the first two symptoms, or any of the symptoms of this is there, then we can think of that the subject may have an episode of a stroke. And T stands for time, because time is very important, as I said, because there is a period, and or you can say window period within the episode of the stroke till he gets the treatment. Why it is known as window period? Because what happens, as soon as the loss of blood supply to the brain is there, then the cell starts, the cell death of the cell starts. But within 4 to 6 hours, if blood supply is restored area, the of cell will not happen, and the cell will have a proper function, and it will minimize the mortality as well as the disability. So this is very important to restore the blood supply within the 4 to 6 hours. So how it can be done? So there, if one has this fast symptom, then we have here it is written that we have to call 911. Yes, it is the number, ambulance number we have to call. Or if you are in remote area where the services, suppose in Indian condition, there in remote area ambulance services are very rare. So try to um, get the patient treated in a hospital where you see that CT scan is available. Why CT scan? Because CT scan is important because we have to rule out whether the subject is having ischemic stroke or hemorrhagic stroke. As I said that 80% of the cases fall into the ischemic stroke. The chances are high that the subject may be having the ischemic stroke, but it has to be ruled out because the treatment for hemorrhagic stroke is totally different, and for ischemic stroke, and if ischemic stroke is there, then one drug known as TPA, that is tissue plasmogen activator, if this is administered within 4 to 6 hours of the episode of the stroke, what happens that this drug has the capacity to open up the occlude blood vessels and restore the blood supply to the affected area of the brain, and minimizing the disability and minimizing the brain cell death. So this is very important time, and always, as many of you are here students, do take care of this mnemonic, that do have that this mnemonic you should remember, and this will help you in identifying the things. And always also, if you are practicing the nearby of 2-3 kilometers, 4 kilometers, you take the list that where CT scan is available in that hospital, you just try to refer the case where CT scan is available in order to avoid the maximum disability or mortality of the stroke patients. So as I said, there is a sign and symptoms. If you will go, sensation is problem. In sensation, proprioception losses are there. Loss of superficial pain, touch, and temperature is there. Motor function, weakness of the one side, either of the side. As we know, there are two hemispheres of the brain, right and left side. If right side is affected, left side of the our limb will have the weakness. If left side is involved, then right side with left side, also known as dominant side. And we all know that in left side other areas are also there, that is the speech area and the vernix area, that is the receptive and expressive speech area. So whenever we see, then there is speech involvement in right sided of the hemiplegia. Then incoordination is a problem is there when basal ganglia is involved. The proprioception losses are due to the motor weakness. If cerebral lesion is there, then we will find the ataxia. So basal ganglia will lead to incoordination, and ataxic type of incoordination in cerebral lesions. Speech and language, as I said, that there will be aphasia, expressive or receptive. So perioccipital region cortex of the hemisphere is then when having the damage, then the speech problem is there. Perceptual deficit is there. Perception is a problem in those patients when parietal lobe is involved. Then cognitive and behavioral changes are there, especially in the acute cases. The patient is depressed, the negative thoughts are there, slow, cautious, insecurity is there. So at that time, the patient cognitive and behavioral changes, you will see he will be sometimes aggressive, also sometimes very submissive. He will not able to follow your commands, also grasping of idea is very weak. And when multiple infarct is there in the brain, then you may observe loss of memory and it is termed as dementia. Urinary and bladder bowel dysfunction, especially in hemorrhagic cases, when the patient GCS, glaucoma scale is not proper or poor, then at that time catheter may be applied. And initially also, if a good GCS patient is there, orientation is there, so catheter is applied, then we should try, or we should see that it should be removed as early as possible, because it will prolonged catheterization may lead to infection. Orofacial dysfunction, swallowing problem is there due to the weakness of the neck muscles as well as the facial muscles when the medullary brainstem is involved. Secondary impairment is one of the things where our role is very important, and secondary impairments occur due to the prolonged illness, that is decrease in range of motion, contraction and deformity, deep vein thrombosis, pain, shoulder dysfunction, deconditioning of the chest is there, and deconditioning leads to respiratory distress of the subject. So we should be doing proper conditioning of the chest in terms of giving breathing exercises and the chest physiotherapy, as well as sometimes the subject may need the ventilatory support for maintaining the oxygen saturation. So what is functional independence? Functional independence can be defined as individual and ability to perform ideal activity of daily living. Autonomy in performing the task ensures a person's ability to live alone in a domiciliary context. So in common way, functional independence has been termed if the subject is able to do the ideals such as feeding, grooming, bathing, upper body dressing, lower body dressing, toileting. It has been designed by the functional independence measuring scale. These things, this tool, the 18 tools has been defined. But apart from what happens, that see that he's able to do, but what happens in order to perform the task in a very fine manner, in a very specified manner, we need to give more stress for the more specified functional independence in terms of the transfer, locomotion, or communication, or social cognition. These things has to be given, and for this we need to have modified independence also. In that term, we need some assistive device aid to maximize the functional independence of the subject. Supervision is to be needed to be done, that is known as modified dependence. Supervision in terms of cues, verbal cues, visual cues, any activity based things such as which we can see through the biofeedback and all that. This has to be given to the subject to complete the activity. So for this, we can start with early mobilization. Early mobilization, some of the studies suggested earlier that it should be done or it should not be done, but most of the studies suggested that looking into the secondary complications, it is advisable that when the subject is stable in terms of vital capacity, in terms of respiratory rate, in terms of blood pressure, in terms of oxygen saturation, then early mobilization can be started, because it helps in decreasing the secondary complications such as TVT, pulmonary embolism, pressure sore, and even when the subject is on ventilator, the vitals are stable, then we can make the subject sit and stand and even walk for a few meters, suppose 2 meters, 3 meters, up to 6 meters, so that his functional come back to the his functional ability as soon as possible, as well as this will improve the ventilation of the subject, and when lung capacity will increase, he may be weaned off from the ventilator as early as possible. So early mobilization has to be done, and it should be started within for 12 to 24 hours if the vitals are stable. And we have to take close care on those cases, especially in the acute phase of the stroke. And at any moment we find that his vitals are not proper, then just give the rest to the subject. Don't continue with the treatment. And also consult with the physician, and with the physician consultation also we can start the early mobilization. So our goal for rehabilitation or physiotherapy, as I said, to improve the range of motion, prevent deformity, promote awareness, improve trunk control, symmetry, improve functional mobility. And in that order, first thing is the positioning. Positioning is one of the first consideration during early rehabilitation. The aim of positioning is to support, prevent the development of abnormal tone, to improve the, yes, yes, any problem? Hello.
Please continue, sir.
Okay, thank you. So ability to change a position and posture is affected in many individuals post-stroke and result in varying degrees of physical impairments. Therapeutic positioning aims to reduce the skin damage, limb swelling, shoulder pain or subluxation, shoulder subluxation, discomfort, maximize the function, maintain the soft tissue length, because contracture happens, so soft tissue length has to be maintained, and this is to be done with the positioning, because since beginning if we are doing this, this will maintain the properties of the joint, this will maintain the properties of the soft tissue, this will maintain the properties of the muscle, and will help in gaining good functional outcome when the patient is well oriented. And this also helps in decreasing or keeping the muscle tone in a intact position, or you can say the normal muscle tone. It helps as far as it can be done. So most appropriate position is to be designed for these subjects. Appropriate positioning is to be done in lying on the back, lying on the back, and proper positioning of the upper limb, lower limb, as well as the trunk is important. Then positioning of unaffected arm, lying on the unaffected side, and lying on the affected side is very important, and this has to be done in a proper way to maintain all the properties of the muscle, of the bone, of the joints, everything. So while sitting also, we have to maintain the upright position with trunk and head in midline position. Symmetrical weight bearing on both the buttocks should be encouraged. While sitting on the chair, hip and knee should be positioned. So rule of 90 has to be followed. Means rule of 90, that is ankle and knee, they should be in 90 degree, knee and hip should be 90 degree, hip and trunk should be in 90 degrees. So this will help you in maintaining all the soft tissue properties. So we have to be very careful mobilization, because we are not careful, then sometimes for the shoulder joint what happens, that dislocation may happen and it may lead to some adhesive capsulitis. So subluxation, we have to prevent that, we have to take care of that also. We have to take care of the contracture, we have to take care of the increased tone of the muscle, because there is increase in the tone of the muscle, and due to that increase in tone of the muscle, the synergic pattern of the movement happens, and then synergic pattern of movement happens, then it hinders the selective movement. So this I am doing, this is my selective movement, finger flexion extension, PIP DIP flexion, my selective movement. What happens in stroke? Due to higher tone in the muscle, accessory muscles, or you can say the stabilizer, this is the prime movers. If I am doing flexion extension of my PIP DIP, this is the prime movers, and the stabilizers are my wrist extensor, wrist flexor, elbow extensor, elbow flexor, shoulder muscles, all are acting as a stabilizer, and both the muscle is important, prime movers as well as the stabilizer, because in order to have a good functional independence with optimum level of the functional independence, we need to have the both the aspect of the muscle, that is the prime mover, and the our stabilizer to be working properly. Otherwise what will happen, our functional independence or functional outcome will decline. And for example, if there is any a nerve injury to the radial nerve injury is there, so there is wrist drop. And though all the, if you want to do any of the activity to hold the object, your stabilizers are working, but your prime movers, that is the radial nerve innervation is there, that muscles will not work properly, and your functional outcome will decline, and functional independence will also decline. So we have to maintain that the muscle which in terms of any movement or activity, the prime mover as well as the stabilizer are working in coordination. There is should be a proper interplay between the muscles. Interplay is very important. What happens in stroke, that this interplay of the muscle stops it due to the increase in the tone of the muscles. So we have to decrease the tone of the muscles as far as we can decrease. Okay, we can't decrease it 100%, but we should try to achieve the optimum the level where we should decrease the tone of the muscle, and this will help us in gaining proper and very good functional outcome, leading to good functional independence. So apart from this, transfer is one of the important thing. Early transfer has to be taught to the subject, that is to get up from the bed to chair, and chair or wheelchair. So this will help the subject in ease of transfer, and then later on gait training has to be done to achieve the functional independence. So oromotor activities, that is the swallowing, chewing, so that this also hinders the subject's activity of daily living while feeding and all that. So this should be initiated, and this should be helpful and subject to gain the muscle movement, and swallowing and chewing function should improve in the subject. So most of the techniques are also applied for this to increase the functional independence, that is the NDT approach, proprioceptive neuromuscular facilitation patterns to be given, Bobath, other Broomstone roots approach. These are approaches which has to be applied nowadays. What of things are coming, that is the biofeedback is there. Technology is also helping, virtual reality, functional electrical stimulator. These are also helping us in getting the better functional independence or outcome in the subject of a stroke survivor. The goal of physiotherapy treatment is to optimize the improved postural control and to achieve the selective pattern movement for the functional independence. And how we should achieve the functional independence? So it is not the one area where we have to concentrate. We have to take the body as a whole, and then we have to identify the actual problem. Then only with the holistic approach only we will be gaining the optimum level of the functional independence in the subject of a stroke survivor. For that we should be having the knowledge to analyze the normal. Suppose we, for example, if we are doing any reach activity, overhead reach activity, what we need to have? We need to have the extension of the head, extension of the trunk, as well as our hand should go overhead. So this is the normal pattern for overhead reach. Until unless this pattern you are not able to analyze it, then you will not be able to analyze the deviation, and you will not be able to analyze the shortcomings in the movement. So if you are not able to analyze, then you will not be able to design the appropriate treatment technique. So it is not only the hand which will help you in gaining the overhead activity. The role of neck, role of trunk, role of thoracic region is equally important to achieve the optimum level of the functional outcome. So we have to work on all those components and activate the muscle of those areas also in order to get the proper functional outcome, to have a proper functional independence. So what is the aspect of the clinical practice? In clinical practice, we should design the reasoning. Yes, why it is happening? Why it is happening? Okay, he is able to lift his hand up to the functional level, but why he is not able to achieve that functional task? Yes, there may be other reason also. So look for the thoracic muscle, look for the scapular muscles impairment, look for the elbow muscle impairment. So there are other aspects. So this will design your reasoning, give you the reasoning, as well as you will come to have a proper movement analysis. So there should be integrated approach. This will lead to integrated postural control, and then it will lead you to task directed movement. The use of sensory and proprioceptive input should be given, and this can, in NDT, it is given through the facility technique, and that facilitative technique is a soft approach to influence the skin receptor of the patient through contact to activate the muscle, and when muscle is activated, the therapist guide the movement. So here, through facilitation, we activate the muscle and then we recruit the muscle for the task performance. This is very important, and there are certain cues to be given in form of verbal, in form of visual, so that the subject will have better understanding of the movement, and better understanding of movement will lead to good functional independence. So facilitation aim is to achieve the best alignment of the trunk and the limb for the task, to inhibit the abnormal tone through weight. So what happens? The abnormal movement sets in. If we talk about the gait, what happens that when the subject is walking, he will take a circumductory gait. That is, the abnormal pattern of the movement has set in, and the normal pattern of movement is absent in the gait. So what we will ask the subject, we will show the visual cues, the verbal cues, or the facilitatory technique in order to maintain the normal pattern of the gait, that is the heel off, toe off, knee flexion, hip flexion, without having the circumductory gait. So these will help us, help the subject to gain the more functional outcome. And one more thing is important in that, that is the that is the role of plasticity. The plasticity plays an important role, and it has been given, it is now being given a lot of importance in recovery, especially on the neurological cases of a stroke, Parkinson's, and any other neurological cases which leads to neuromuscular disorder. These plasticity is helping to gain the maximum functional outcome or functional independence. So what is plasticity? Plasticity is the ability of the brain to adapt the movement or change the movement according to the feedback, according to the practice, according to the repetition, and according to the environment. Earlier, what it was said that the brain cannot change after the age of 7, 6, or 8 years. So that is the learning stage, and after that the brain doesn't changes. But a lot of researches have proved now that brain can change at any level of the time, any level of the period, by repetition, by feedback, by environmental factor. So brain can change at any time, and this changing of brain is known as plasticity, or you can say the neuroplasticity. Some stages are more plastic, that is the birth, puberty, and the damage. And here there is damage in the brain, and due to damage, the certain activity which was done earlier, it is not been received by the brain, the signals are not there, so it leads to abnormal patterns. So at this damage time only, we are trying to give the feedback, the repetition, or the practice to the subject to gain the normal pattern of movement. So this may help in gaining the subject the normal pattern, or you can say the optimum level of the functional output or functional independence. Proprioception is one of the also main factor, because this also is important for somatosensory, visual and vestibular inputs, because somatosensory inputs of the foot and hand and neck and trunk receptor, this is very important, because until unless our writing reflex will not improve, and this will improve due to the proprioception only, and the movement and the stability in the neck and the trunk muscles. So we have to work on these also to gain or assess these things, that how much the neck control is there, the trunk control is there, how much is the proprioception of the all the joints. So these will give the feedback to the brain, and accordingly the brain will adapt and have the normal movement, which will lead to normal postural tone. Normal postural tone while sitting or standing, that is against the gravity. The able adaptation is very important, and this leads to changing of the BOS, that is the base of support. So base of support is also important to achieve the selective functions. Functional goal. Postural tone is adaptable and varies through different part of the body in response to have a desired goal. So base of support is important. Base of support is the it is the contact of the body with the surface, so that there is proper balance in the subject to perform any of the functional activity. So reciprocal innervation is also important. As I said, that muscle have their interplay, so they do interplay among themselves. Suppose the agonist antagonist is there, or suppose you are doing a flexion extension, then what happens that of elbow, if you are flexing it, then there is contraction of the biceps and then lengthening of the triceps, and if you are again going to the extension, then the contraction of the triceps and extension of the lengthening of the biceps is there. So there is an interplay, and if this interplay will stop, then what will happen? The functional outcome will not be there, and this function will not happen. So interplay, so reciprocal innervation is very important, and interplay, this will help in having the interplay between the muscles, and this will decrease the synergic pattern of the movement, and will help us in having the proper sequence of selective movement in appropriate alignment for the achievement of the goal. So balance reaction is very important. Against the gravity, balance should be there. For that, base of support is important. Base of support of the surface contact should be proper, so that the subject is able to do the proper functional outcome. And the base of support helps in body alignment with a given goal, and this will improve the posture also, because the posture is impaired in this. The subject is tilted one side, the neck is flexed, the shoulder is forward, our lower limb is externally rotated. So these postures, when the base of support is fine, then we can improve these posture, and this posture will help us there. You can say they are equal to movement. If your posture is fine, your posture is good, then you will have a proper functional outcome, and the functional independence will be at the optimum level. So writing reflects that trunk writing, head writing, writing, these should be very important to regain the functional outcome, and this helps in keeping the body in a midline, or you can say in aligned position. So body alignment is very important in order to gain the pattern of movement of the given goal in an appropriate position against gravity. Use appropriate base of support helps for the posture, and this posture helps to gain a proper movement, and this proper movement will help us to gain the control of activity. So take home message for this is that you should always assess the subject, assess for the posture, assess for the muscle tone, assess for the strength, assess that whether the subject is able to perform the selective movement, or the movement is synergic pattern of the movement. If it is synergic pattern of the movement, then try to achieve the selective pattern of the movement, maintain the balance of the movement, and for this you have to increase the repetition. It is not only the 10 repetition, 5 repetition that will make the subject functionally independent, or will gain the subject will have optimum level of the functional outcome. It is n number of repetition and practice which will help you, or which will help the stroke survivor to gain the maximum functional outcome or functional independence. So it is when you give a session to the subject, then try to give the home activities in such a fashion that his repetition and practice is maximized, and he is able to do n number of repetition and practice, and which will also lead to the increase in the exercise tolerance. As he will do more exercises, the more the flexibility of the bone and the muscles will be there, and more flexibility of the muscles and the bone will lead to a proper functional outcome, and also will lead to optimum level of the functional independence, apart from the ADLs what he is able to do. So this was the gist and the key of the functional independence, that what we should look for better functional outcome in the stroke survivor. Thank you.
With the
Voice is not there, Dr. Ketki, or mute.
Thank you, sir.
Yes,
Thank you
fine.
so much for providing your valuable guideline to us. Now, with the permission of speaker, I would like to request participants to open the webinar for question answer session. If anyone,
Yes, definitely. The questions are there. Then
if anyone having question, please raise your hand.
no question. So I should ask the question from anybody.
Yes, sir, definitely.
So there is Agarwal Sanskruti. So what did you understand? Anything which you didn't understand in my talk? Agarwal Sanskruti Agarwal is there. I am asking to him or her. I am not able to. Her.
Sanskruti Agrawal.
So now the people have started leaving fast as I have started asking questions.
No, sir.
It was 112 and now it's 107.
Sir, okay, I think there is no questions. Now, I request to webinar share our Vice Principal of Dr. APJ Abdul Kalam College of Physiotherapy, Dr. Neeraj sir. Please give us valuable conclusion note to the participants. Thank you. Over to you, sir.
Thank you, Dr. Ketki. First of all, I'm very extremely thankful to Dr. Prabhat Ranjan sir for sparing his valuable time. It was a matter of fact that once we approached him, he didn't take too much time to accept our invitation. We are very much thankful to you, sir. And yes, of course.
Thanks for inviting me also. It is a great honor to be on this platform.
Such a humble response, sir. Thank you so much. And yes, indeed, the topic of today's webinar was very much fruitful for the participants. Like if you are dealing with the stroke patient, what are the things has to be keep in mind? All those things, sir, have emphasized very nicely. Thank you so much for this. And I would like to tell all the participants regarding sir's contribution towards our profession. Like whenever there is a matter, like for the council or for the upliftment of our profession, sir is always stood first in the line to work hard for our profession. I know him for last, I guess, sir, 8 years or maybe 7 years. I don't know, maybe. And from that
6-7 years we are in touch.
So sir is always very much encouraging for us to work for our profession. And it is sir's vision and like you can say a mission. In the time of sir hunger strike, I remember that hunger strike is at Jantar Mantar. I was also there for the whole day, and it was like a very appreciated initiative taken by all of us.
Yes.
And I also like to tell everybody when the matter of council formation, sir is always there. When the bill is tabled at the Lok Sabha or Rajya Sabha, sir is one of the physiotherapists, maybe the first who come up with the draft and all the information regarding all those things. So I don't want to miss the chance if sir is here. So I would like to ask few questions about the council formation also, sir, if you permit.
Okay. Yeah, definitely you can ask, no problem.
Sir, basically, two questions are there in the mind of many physiotherapists. Like, what is the current status of our council? And the second, sir, question is, since last 2 years, we came to know that the draft bill was tabled in Lok Sabha, was approved. It was in Rajya Sabha, then it sent to standing committee. And from there, just 2 or 3 or 4 months back, we came to know a new bill came into existence. So what is the difference between the both two bill? This is the second question. The first question, sir, what is the current status of the bill?
The current status of the bill is that it has been introduced in Rajya Sabha in the name of National Commission for Allied and Healthcare Bill. Earlier, it was Allied and Healthcare Bill 2018. This one is National Commission for Allied and Healthcare Bill 2020, which also includes the physiotherapist as a professional in this bill. So as you have asked it earlier, what is the difference between the earlier bill and this bill? I will just go with the some bit of history. So history is that in 2007, what happened that a bill came in the name of Physiotherapy and Paramedical Council of India. In that bill, what happened that it was fine that they had given a separate chapter of the physiotherapy in that bill, but one drawback was there that the bill definition was not acceptable, because the bill definition said us as a medically directed profession. So we did lot of campaigning at that time, lobbying at that time, and this bill was introduced in Lok Sabha in 2007 and was kept by Lok Sabha. It was sent to standing committee, parliamentary standing committee in 2008, and in 2008 we did lot of lobbying, and no, it was 2006, 2007 report came. 2006 we did lot of lobbying and met the then chairman, that Amar Singh was late Amar Singh was the chairman of that committee, and he helped us a lot. And when he gave the report, he gave that we are a independent practitioner. And what happened that the bill was again tabled with the recommendations of the standing committee in 2007. But what happened that the bill was sent to ministry for the changes, the necessary changes which was given by the parliamentary standing committee in 2007, and due to administrative things or any other things, it was not tabled again, and it lapsed. It lapsed because it was tabled in Lok Sabha, and what happens, as the Lok Sabha dissolves, the whatever bill is there, that also automatically expires. This time what happened, in 2017, the Allied and Healthcare Bill was tabled in Rajya Sabha. And when it was tabled in Rajya Sabha is a permanent body of the parliament. and whatever bill is there, it doesn't lapse if the Parliament of Lok Sabha is dissolved. So this was the benefit with us, that this bill didn't lapse. That time it lapsed, and we have to start again with a new process. Then in between came the NCHRH bill, National Commission for Research and Health. It came. So in that also MCI, in that what was the provision, that medical profession, dental profession, nursing profession, all the paramedical profession, allied health professional, all the professionals were inculcated in that bill, and MCI has a lot of objection for that. So what happened, that when it went into the standing committee in 2014 or 13, so the standing committee, they represented, and a standing committee also said to withdraw the bill, and that will be withdrawn. So this bill in 2017, Allied and Healthcare Bill, was tabled in Rajya Sabha. It was sent to standing committee, and in a standing committee, basically this bill had a very good definition, and this bill has given, by the definition, this bill has given us the independent right of practice. That is one of the important thing, and due to this only we thought to accept this bill, because what happened, that we had a lot of discussion with the ministry officials, with the minister. They were, though our demand was for the independent counsel, but they were not agreeing to that. At least we should have something in hand that should legally state us that we are a physiotherapist and we are an independent practitioner. So this bill at least provided that definition. So we thought to at least start from somewhere, because we have been lacking the regulations since last 60 years. At least we will be regulated, so from this we can have a growth process started. Our professional growth may start legally. There is no legal backing of our physiotherapy profession, and due to this we are facing lot of problem each and every day. Sometimes some certificate course is coming, sometimes some diploma course is coming, sometimes 2 years course coming, and due to this the no regulation is there, malpractice is increasing in the society. So at least this will help to curb the the malpractice in our profession and help us in professional growth. So the main thing, what is the difference between the Allied and Healthcare Bill and National Commission? And MPs are also changed. So in the standing committee, some members are from Lok Sabha, some members are from Rajya Sabha. So Lok Sabha members has to be replaced if they come after a fresh mandate. So they were replaced, and then a notification was done, and then it came for the public hearing. We were there to give our suggestions. Mostly one thing we had the concern that there should be a separate chapter at least for the physiotherapist in the bill, so that we should have our own representative. Earlier in the bill, what was there, that the head of there are two things in this. One is the commission. Now there will be, earlier commission was not there, only one body was there, and that was to regulate all the profession, and in that body also the head was the you can say the administrative or bureaucrats were the head. Our objection was that the professionals which are included in this bill, at least those professionals should head the bill. And in National Commission has been, commission will be above. Then in that commission, the provision is that the professional which will be registered under this commission will be only heading this commission. So this is one of the major change, and this will I can't say that physiotherapist may be leading, but any of the professionals. So sometimes chances will be there that the physiotherapist also may come and lead the commission. It may be optometrist also, it may be the occupational therapist also, it may be nutritionist also. There are 10 categories has been defined. National Commission, then 10 professional council. There are 52 profession in this commission, and in this 52 profession, they have clubbed it into 10 professional council according to their nature of job. Suppose MLT is there, so MLT is having lot of different sub branches. Those sub branches have been clubbed and they have been given one professional council. We are also having Physiotherapy Professional Council in this bill, where our representatives will be heading this professional council and reporting to the National Commission, and whatever decision will be taken, this will be taken in consultation with the professional council. So in 10 professional council, we are having a separate professional council in this bill. This is one of the major change. The two changes are major. One is the heading, who will head the commission, and the second is the professional council which has been given under the provision of the commission. So this is one of the things. So we will have our say, we will have our representative now. Earlier we were not having a representative in the government setup. So at least the government will come up with any policy or any. Right now we have the one thing we have seen, that assistive device thing has come through the ICMR, but what happened that no physiotherapist has been consulted for that in absence of any regulatory body. Now these type of things, policy making things will come. Definitely government will turn up to the commission, and the commission will designate the professional council to at least draft the things for the benefit of the profession, or whatever there is. It is not always that government heeds to all the professional demands, but at least whatever demand will be there, it will be in the interest of the profession, by the professional, and for the professionals. This is one of the important thing which will be helpful for us to have a proper professional upliftment, and this will also help us in research activities or academic activities will be regulated. There will be certain norms for that, yes, you should have at least this much of faculty, this much of a professional, this much of professional qualification of a faculty, how they should be promoted. These guidelines will be there, and that will be implemented in the if regulation is there. Now UGC is having, but what happens that UGC is not having a statutory power to say, you can say that penalization is not there, but this commission will have this statutory power. He can remove the affiliation of the college. He can say that this is not proper thing going on, so your affiliation will be removed, and you so have to pay this much of penalty also. So this will be one of the things which will be happening in academic sector, as well as it will regulate our practice also. Malpractice will also be checked. This is the main gist behind this National Commission, and I think this has been introduced, and that old bill has been withdrawn. This new bill after the recommendations of the standing committee. So all the administrative, or you can say the parliamentary procedure is being now done. A cabinet has approved. Now only it has to be passed from the Rajya Sabha, and then onwards Lok Sabha, and then last thing will be that the signature of the President of India, and this will enact the bill. So it is in last leg. We are in last leg. Hopefully, due to Corona, our ambition is not fulfilled, because it has to be. It was supposed to be done in 22nd March. This bill was introduced in the cabinet. Cabinet approved it on 20th March. 22nd March, what happened that Parliament was adjourned. And then again in September, it was the Parliament session was there, but it was for 24 days or 23 days. But after 10 days, due to increase in the COVID cases, it was again adjourned. Otherwise, in this session only it would have passed from the, at least from Rajya Sabha, it would have been passed. And then next session we have to wait for that. It should pass from both the houses, that is the Rajya Sabha and Lok Sabha.
Right, sir. It's a very information, sir, you have given. I'm sure most of us were not knowing about the current status of our bill and what is the status of council. It's a very vital information.
In just we are in last leg of having a regulatory mechanism for our profession. It is just a matter of time. Some parliamentary procedure is left, and we will be. I am hoping that by February if anything untoward incident in the parliament doesn't happen, because a lot of time there is a lot of obstruction, everything. And ministry is also keen to get it regulated as early as possible. So by February, March, we are expecting that we will have a regulatory mechanism for our profession.
That would be very great, sir. That would be very great for our profession. And yes, I'm sure all our participants would get enlightened about the current status of our physiotherapy council or bill. It's a very good thing, sir. So in a matter of fact, sir, we can say we can wholeheartedly welcome this bill, na, sir, this time. This is a good for us, na?
Yes, we should, because see, what is the aim of any of the bill is to regulate the education and practice, and this bill is fulfilling that aim. Even the Maharashtra State Council is having a independent council, but the aim is same. Above that aim and objective, the council cannot do anything. So there is limitation for the council also, but it is a representative body of a government, and within the objective of the council, the profession can be regulated, and that objective is surely and certainly being fulfilled in this omnibus council also. It is a umbrella council, but our aim and objective, what independent council is having, is being fulfilled in this council also.
That's very great, sir. That's very good. Thank you so much, sir. Thank you for your wonderful enlightenment about this topic. I'm sure we all are very much get benefited about this. Thank you so much, sir. Now over to
thank you, and thank you for inviting me on this very platform. I'm thankful to all the faculty of Prabhat Institute of Physiotherapy, as the management, who have given me an opportunity to talk in this platform and explore my experience on this platform. Thank you very much, and best of luck to all the participants for a better future, better professional future.
Thank you, sir.
Okay, should I leave now?
Just
Dr. Ketki, or unmute?
Yes, sir. Thank you, sir. So for providing the current status of council, and now time has to come to say vote of thanks. So I would like to request our coordinator, Dr. Sejal Singhvi, to give us vote of thanks on the behalf of Dr. APJ Abdul Kalam College of Physiotherapy. Thank you, sir. Thank you so much.
A very warm good morning to one and all. I feel immense pleasure to propose a vote of thanks. I, Dr. Sejal Singhvi, Assistant Professor at Dr. APJ Abdul Kalam College of Physiotherapy. I am extremely humble and honored and express my thanks to our Honorable President, Prabhat Institute of Medical Sciences, Dr. Rajendra Vikhe Patil Sir, and Vice Chancellor, Dr. Y.M. Jayaraj Sir, for encouraging us and providing us opportunity to organize such webinar. I would also like to thank our webinar chair, Dr. Neeraj Kumar Sir, Vice Principal and HOD, Orthopedic Physiotherapy Department, Dr. APJ Abdul Kalam College of Physiotherapy. I express my regards and gratitude to Dr. Prabhat Ranjan Sir, Neurophysiotherapist at Neurology Department, AIIMS, New Delhi, to spare his time from busy schedule to grace this webinar with his extremely relevant address on role of physiotherapy in achieving functional independency in stroke. I thank organizing team members, Dr. Singaravelan Sir, HOD, Neurophysiotherapy Department, for showing confidence in us. With his feedback, it was not at all possible. I also thank Dr. Ketki and Dr. Komal for teamwork we share. I extend my thanks to Mr. Mangesh Sir from Department of Education Communication Media Center, Pravra Institute of Medical Sciences. Most important contribution of IT Department of Pravra Institute of Medical Sciences, Mr. Mahesh Tambe Sir, Manager IT, and his entire team. Special mention Mr. Vikrant Shetty Sir for his technical help. And last but not the least, all the participants who have been part of this live session on this wonderful morning. Thank you all and have a good day ahead. Now,
Thank you.
It's time to test your knowledge about stroke. So I request all the participants to attend the quiz which
Dr.
we have attended. Yes,
Dr.
sir.
Sejal,
yes, sir.
This webinar is over now.
Yes, sir, just one information I would like to share. We have also organized online quiz and the link is provided in the chat box. So I request all the participants to go through that link and please participate in the quiz and provide your valuable feedback. Thank you.
Okay. ठीक है प्रभात सर, फिर मिलेंगे आपसे सर.
Thank you.
Thank you, sir. Thank you so much. Now, this webinar session is over. Thank you.